Hey guys, welcome to our lecture on assault, abuse, and neglect. This is oftentimes a topic that can strike some chords with folks, and so as we just go through the lesson here, I want you to keep the position in the back of your mind, not so much as a provider, but as a patient or a close friend, maybe even, who's working or dealing with someone who might be suffering from this abuse or assault or neglect. I want you to try to take the perspective of the patient rather than the provider as we go through some of this. I think that will help with some of the clarity as we work through the lesson. Let's go ahead and get started. The topics that we're going to talk about today include the four primary areas. There are some additional areas that are covered in some YouTube videos in the online lesson, but these are primarily partner abuse, elder abuse, child abuse, and sexual assault. We also go into different components for human trafficking. We also talk about hate crimes a little bit in the online lesson. So let's talk about the facts. Nearly 3 million children are abused every year, and out of that, over 1,000 die. That's a lot of kids that are dying unnecessarily, a lot of people that are dying unnecessarily. 2 to 4 million women are battered each year, and 700,000 all the way up to over 1 million elderly people are abused every year. So this is something that in your career you are going to face. And your actions and your ability to follow through and providing an honest opinion based in facts for your patients is going to be the best way that you can actually help them get the care they need. We know that abuse and assault transcend gender, race, age, and socioeconomic status. Socioeconomic status referring to their place in the economy or how much money they earn, things of that nature. So there's no real component that takes abuse, assault, or neglect from anyone else. Anyone is capable of having this happen. And what we want to do is be able to try to recognize what that process looks like. Let's start with partner abuse. We know that partner abuse by definition is physical or emotional violence from men or women towards their domestic partners. We know this doesn't happen in just male and female relationships. It can be female to female or male to male, or gender neutral even for that matter. The idea behind it is it's violence, physical or emotional, towards another. In this case, we're talking primarily about the abuse of women, but again, it can happen across any spectrum. The abuse of women by men is more widespread, though. Right? We see that more often. Males are less likely to report abuse, though, than females are. So even though we know that dominantly it's females that we're seeing that are those that are abused, in the small cases where we do have men being abused, they're less likely to talk about it. They're less likely to report it. And again, this happens in same-sex couples as well. Now, reasons abuse is not reported, well, here they are. Fear of reprisal, reprisal, I can't say that, fear of humiliation, denial, lack of knowledge, or just lack of resources. A lot of times those may be financial, but just the ability for them to actually go and get the help that they need. We identify partner abuse in 3 different categories. Physical, which may exacerbate certain medical conditions and other underlying issues because of the physical assault associated with it or abuse. Verbal, right, more of a spoken form or written form, and then sexual abuse. And this could be a form of physical abuse, but we also refer to it as its own intentional component of sexual abuse. This can happen in both married couples and those that are dating or those that are not necessarily involved at all together. And the idea behind that is that, again, knows no boundaries. Risk factors for partner abuse. We know if the male is unemployed, there's a bigger risk for abuse. If males use illegal drugs at least once a year, there's a higher likelihood for abuse. Partners who have different religious backgrounds oftentimes lead to abuse. And then things like family income as being below the poverty level, or believe it or not, even partners who aren't necessarily married oftentimes see an increased risk for abuse. What about partner abuse? Well, it goes on to talk about either the partner is violent towards the children at home because of it. Males did not graduate from high school, so there's a lack of education. Male is unemployed or has a blue-collar job. Male is between 18 and 30 years old, and then male saw his father hit his mother. We have to remember that Abuse is a learned trait, and it is passed down from generation to generation based on what we see and interact with. Characteristics of a partner abusers. These are more common in lower social economical status. They have a history of family violence. Again, that's going to be critical here. And then abusers usually exhibit overly aggressive personalities. They're typically very easy to get riled up or easy to get excited. And then the abuser often feels a sense of remorse or shame after the abuse. That's what's crazy about it. They perform an abusive component on their spouse or partner, and then in turn afterwards they feel bad about it, but it doesn't break that cycle. Not always. Some characteristics, pregnancy is a big one, substance abuse and emotional disorders, right? Those are going to be more likely that those characteristics of abused partners. The victim may seek to protect the attacker oftentimes as well. You ask yourself, why would someone who's in an abusive situation want to be protected or want to protect their attacker? Well, a lot of times you have to, again, look at it from the victim's perspective. In this case, their world may revolve around the items and social economical status that's provided by the abuser, right? So if they were just going to say, well, I'm just going to go ahead and report my husband and I'll get it taken care of. Well, it's not quick. It takes a process for those things to happen. And in the meantime, there could be no place for that individual to stay or food or shelter. Some basic necessities oftentimes will draw them away from reporting where they know they should, but they just can't because of their situation. Now, when we're dealing with a battered patient, we have to recognize our approach. It has to be a little bit different than we would for any other patient. Obviously, it's a little bit more of a sensitive situation. We want to use direct questions. We want to make sure that what we're asking is specifically related to the information we need to know. We want to avoid all judgments if possible, right? We don't really need to know what's going on or what's happened up to lead to this. We don't need the full background story always. We need enough information to get the information that's required, and then we need to make sure that while asking those questions, we limit and avoid all judgments coming from us. We also know that we need to listen very carefully. My mother always says, the good Lord gave you 2 ears and 1 mouth. You should use them in proportion. You should listen twice as much as you speak. And I think that's important, especially in these abused patients. We want to encourage to regain control of their lives. We want to offer knowledge that you may have of community resources and advise the patient to take all the necessary precautions before returning home. Otherwise, we're going to end up with another episode of CSI New York, where someone's coming home and now they're deceased. Now there's been a murder or there's been some other type of component that's led to this because not all necessary precautions were taken to ensure a safe environment for that individual. So that was partner abuse, spousal abuse. Now let's talk about elder abuse, because this is something we also see a lot. We know that the elderly patients are the #1 group of population in which we serve. So the problem of elder abuse is expected to grow as the population of geriatrics grow, right? As the baby boomers grow. Now, when we think about elder abuse, oftentimes that's abuse based on their living environments, based on maybe the care they can provide to themselves or the care that someone else is providing to them. And so we must remain alert to elder abuse. It's not outside of the scope of things we will see, but sometimes you have to make sure that you're keyed into it to figure it out. So what are some of the signs we might see? Well, things like physical abuse, emotional abuse, sexual abuse, neglect by either the caregiver or the patient themselves. We may see financial exploitation and then even healthcare fraud that can go along with that. When we try to identify what elder abuse is, we've got to break it down a little bit further. Domestic elder abuse takes place when an elder is being cared for in a home-based setting. That would be considered domestic abuse, or domestic in this case, more specifically elder abuse. Institutional elder abuse occurs when the elderly is being cared for by a person who has some type of legal or contractual responsibility. So typically you're paying them for their services, like a nursing home or a visiting nurse or a stay-in-home care. That's an example of what some of those institutions might be. Now, there are some theories about elder abuse. We know that caregivers definitely feel stressed. They feel stressed and they feel overburdened with the number of things that are going on in their lives. That leads to a more perfect condition, more perfect storm to be an abuser because of that, even though that they're caring for one of their loved ones. We know that elders in poor health are more likely to be abused, and it creates this cycle of violence. And typically, this cycle of violence is generated from past family experiences. And so if the elderly was an abuser themselves, they are in turn more likely to be abused as an elder, if that makes sense. We also know increases proportionately with the personal problems that are going on with the caregiver's life. So the more problems that the caregiver has, the more stressed or overburdened they are, and their history of violence all creates an environment that makes them more likely to perform elder abuse. We also know that most common cases involve elderly women abused by their sons. Again, we know males are more likely to be abusers. Most frequent, not to say that women can't though, most frequently it occurs among people who are dependent on others for care. So it's not just like someone's just going to randomly go up and rough up an old guy, but it's typically related to some type of dependency for their care. And in cases of neglect, elders that are abused most commonly will live alone. But you go, geez, why are they more likely to be abused? Remember, they're more dependent on that home care or the assisted care that they need to remain home. That's another burden. Here again, you look at the characteristics as far as perpetrators of domestic elder abuse. You can see that the primary age group that deals with this, 32.5%, is adult children. From there, you can see that all others kind of fall into the bulk of the category of 18.2%. And then we also start to look and see things like spouses and then other relatives are very high. All right, let's talk about child abuse. Child abuse is one of those topics that typically we have a large discussion in class, and we'll base this based on your experiences, and we kind of create a hypothetical situation. I'm going to leave that for our Zoom lecture, but I definitely want to make sure that you understand the gravity of child abuse. And a full throttle approach, right? Running in and just going to take the kid and do what you need to do and be in control of the situation oftentimes is not the most effective way of stopping the abuse cycle. It may stop it momentarily, but it's not necessarily going to alleviate the problem. And so sometimes we have to have a lot of tact when we deal with abusers of children or dealing with the child themselves. Let's dive into that. So we know that child abuse has a wider range of different things that we typically would see. One of those big things are physical, and the other ones is emotional, and then sexual. Those are the big three that we typically deal with when we're talking about child abuse, right? The range that exists. Because we're dealing with physical, emotional, neglect, sexual assault, all these things, right? So all of these areas can be impacted based on the individual or the child's caregiver. And so we really have to take a look at that recognize that kids can be abused in more than just one way, more than physically, more than sexually, but also emotionally. Characteristics of child abusers. We always say it takes a certain type of person to be a child abuser. Well, to a certain extent, that's true. Here's some of those characteristics. We know that they typically use or abuse drugs and or alcohol. They're oftentimes dependent on those things. Remember, they oftentimes will feel bad about the fact that they performed some type of violence, and then they're going to regret it. Oftentimes they turn to drugs or alcohol for that, to kind of mute or subdue that feeling. We oftentimes find they have some level of immaturity, and they have a preoccupation with themselves. They're awful self-centered, self-focused. They oftentimes will lack feeling for the child, rarely looking at them or touching them. You can very easily tell that there's not that bond that you would typically see between a parent or a caregiver and a child. And then the last one is apparent lack of concern about the child's injury, their treatment, or their prognosis. When a kid gets hurt, I can tell you firsthand as a parent, and then also be on the other end as a paramedic, parents are very concerned about their children. They're going to be very concerned about what's going to happen now, what's going to happen next, what's going to happen 10 weeks from now, and then they're going to be there for that child typically right along that process. Someone who's in a child abuser, either they're going to lay it on so overwhelmingly thick that you can tell that something's not quite right, or they're just not going to care. As we've said before, make sure you keep full batteries in your BS-o-meter because you're going to see a lot of that, unfortunately. We also know that there's open criticism of the child that's going to happen with little indication of guilt or remorse for involvement in the child's condition. So you may often find that they're going to criticize the kid for whatever happened to them. Oh, geez, Timmy, you're so dumb. I can't believe you would fall down the stairs like that. This happens. This type of stuff happens all the time. Well, you don't typically criticize someone when they're hurt. If that's the case, maybe there's a potential risk there's some abuse going on. And then little identification with the child's pain, right? Whether it's physical or emotional, they just don't really identify with it. Characteristics of abused children, on the other hand. You're going to see children crying, often hopelessly, during treatment, or they're not going to say anything at all. They're going to either be on one end of the spectrum or the other, almost completely unconsolable or completely quiet. Those should be alarming things to you. They're going to try to avoid the parents or show little concern when the parents are absent. Maybe they even feel better when the parents are absent, something to think about. And unusually, they're going to have a fearful or worry about their physical contact, right? They're very wary of physical contact. So you go in there and you're going to try to check something, they may have an instant reaction to pull back. That's going to be a prime example of physical contact, because the only thing that they've had for physical contact potentially after this point is negative contact, negative physical or emotional contact, sexual contact. So we want to try to recognize those signs as well. We also know that they're going to typically be apprehensive and or consistently on the alert for danger. These kids don't turn off their fight or flight response. It's constantly active because it's a survival mechanism for them. We also know that they're going to be very prone to sudden behavioral changes. We talked about being on one end of the spectrum or the other. Now they're going to flip-flop very quickly in their emotions. We may see an absence of all emotions. We may also see the opposite, where they are completely needy. They have a very high level of neediness, consistently requesting for favors or food or different things that they want to do. Pay attention to behaviors that are inconsistent with their age group. We also know that for the identification of abused children very commonly get injured, right? Not all injured children are abused children. My daughter, for example, is a monkey. She loves to climb on things, and she's just over 2 right now. She's got bruises in multiple stages of healing, and lots of different things all over her legs and elbows and knees because she's so physically active. But that doesn't mean that I'm abusing my child. So those are sometimes you have to take a look at both the physical conditions and the emotional interactions that the child and the caregivers are having. There are times, though, that easily we can mistake a child abuse in lieu of just regular components. So a regular assessment findings. Let's look at those. Conditions that are commonly mistaken for abuse include things like car seat burns, scalded skin burns. Chickenpox oftentimes will look like cigarette burns. Hematological disorders can also lead to different sets of bruising. So there's a lot of different things that we deal with. We talk about reflexology a little bit throughout your book. We're not going to dive into that too deep here. And then the Hmong folk medicine practices as well, which is a very unique way of treating conditions. We'll leave it at that. I'll let you dive into that a little bit further, page 227 of your textbook. Car seat burns, here you can see this is a staph skin scald. You can see that these things are going to be definitely signs of abuse or neglect, for even that matter, of a neglect. Maybe the parent wasn't thinking about it at the time and had an issue. Chickenpox, you can see chickenpox that will happen there, and those oftentimes will look like cigarette burns. And then hematological bruising that doesn't make sense, either because of a background, maybe they have some underlying blood conditions we talked about in our hematology lecture, or maybe it's signs of physical abuse. Here's kind of an idea of the bruising chart. This is a really, really great table in your book, 6.2, and it really allows for you to know at what point, color-wise, are you going to be able to tell where a bruise is. So if somebody just says, well, geez, Timmy just fell down the stairs, and look, he's got a bruise to his leg. Well, that bruise is brown or yellow in color, not red or swollen or tender or even blue, or purple, we're going to have an idea that that's an older injury. That's not something that's new. And so this is a really good way of calling someone's bluff, and I don't mean calling them out on it, but I mean recognizing that the injuries aren't consistent with the story or the incident at hand. So we start off with a red or swollen tender bruise. The tissue is very swollen. The inflammatory response is there. We start to see a bluing and purplish color that happens over 2 to 5 days. Then it starts to turn to more of a green, to a yellow, to a brown, anywhere between 5 to 14 days and beyond. And so that's from a study that was done back in 2012. That's a really nice way for you to be able to tap into that idea of, is this patient really hurt right now, or is this an old injury that this doesn't line up with the mechanism? We know within your physical exam, soft tissue injuries are most common indicators of physical abuse. Defensive hand wounds or wounds under the forearm are going to be a prime example, or symmetrical injuries such as like bites or burns oftentimes can give you an idea of that the physical abuse is happening. In the picture you can see that we denote bruising most likely from hand gripping too excessively. With burns and scalds, we commonly are going to see locations of the soles of the feet, palms of the hands, or the back or buttocks. We oftentimes will see it more of like a dipping pattern where the child is dipped into extreme water conditions. And then fractures. Fractures, we know that fractures are not easy to get in a child for that matter, because of the calcification that hasn't happened to the bones. There's a little bit more flexibility, a little more give to those bones. But we will see them in severe cases. Sites and locations of fractures include things like the skull, the nose, facial structures, and then the upper extremities are most prevalent. Head injuries are another component we look at. This is where we see scalp wounds or skull fractures, subdural or epidural hematomas, anything that can happen because of repetitive contusions or repetitive percussion to the head. The other one that we know is shaken baby syndrome. Shaken baby syndrome occurs when a parent or a caregiver becomes frustrated with a crying infant and then shakes them. It can be a very minute time. It doesn't have to be for very long, but it can cause permanent brain damage, diffuse swelling and bleeding and bruising to the brain. So any movement like that is just not good. If you're dealing with shaken baby, it's very similar to like a coup counter coup type injury. You can see that the injury is going to happen to both the anterior and posterior portion of the brain. And it's going to be that component of that rocking back and forth of the brain inside the cranium that's going to lead to the majority of the damage. Their physical presentation will reveal a pale or very pallor type color, and then they're going to have very sleepy, lethargic-like eyes. They're not going to be responsive as you would normally expect the child to be. Abdominal injuries can result from trauma to the liver, spleen, or anywhere in the mesenteric tract. The big thing that we're going to be dealing with here is going to be, we know that their organs are much more smushed together because of the size of their abdominal cavity, and so any physical abuse is putting all those organs at a higher risk. We also want to be able to check for things that are going to be dealing with fetal alcohol syndrome, or what we refer to as crack babies. Fetal alcohol syndrome, you can see it's the top image, the white one here. We see small head, large gap between the nose. We start to see a very short nose, underdeveloped jaw, those different types of components. And so there are physical traits that are associated with alcohol. Eyes are further apart, noses are wider, thinner upper lips, thinner jaw, things of that nature. Another example of just a very small child. I mean, just to get an idea of how small that child is, and this is the case where we're dealing with someone who is abusing cocaine. We also have to be aware for neglect. Abuse is not always the only thing we deal with. Some people just stop caring for their loved ones for a number of different reasons, and that's a primary example of neglect. We see things like the lack of essentials, food, shelter, hygiene. Those are going to be some of the big ones that we see. Things like malnutrition from lack of proper diet, severe diaper rash because of being in the diaper or a dirty diaper for extended periods of time, dehydration secondary to diarrhea, hair loss or thinning, untreated medical conditions, inappropriate or dirty or torn clothing, tired or listless attitudes, and the nearly constant demands for attention. Right? They need that. They crave physical contact. They crave interaction with humans. That's a prime example of someone who may be having neglect. Signs of emotional abuse, typically with the parents or caregivers, is just simply ignore the child. They just act like they're not there. They're not parenting. They're not doing anything. They're often more focused on what they are. They're oftentimes also more likely to reject or to humiliate or criticize the child, especially in public. The child may also be isolated or deprived from normal human contact and nurturing. That is a taught skill, and so oftentimes these children will have long-term conditions that they'll be dealing with because of emotional abuse. We know that a child may be very terrorized or bullied by verbal assaults or threats, and that's going to create a sense of fear. That's going to create a lot of anxiety that they're going to carry with them for a very long period of time. A parent or caregiver may also encourage destructive or antisocial behavior, right? Either going to teach them to be destructive and not care for personal property, or they're going to be dealing with someone who's just, they don't socialize, they don't communicate, they don't go out and interact with others. The child may be pressured by unrealistic expectations of success. We also don't think of that as a sign of abuse, right? We think parents, you want your kids to do the best you can. But at a certain point, when that becomes a burden to the child and their progression, well, no longer is it helpful, right? We don't want to have excessive amounts of pressure for unrealistic expectations. Now, we have a responsibility to record and to report any suspected child abuse, any suspected elder abuse, any signs of neglect, anything that we deem as that someone's in danger. We have a responsibility to make an intervention. And it's important to recognize that the earliest intervention that you can do typically is the best, right? We want you to have as much early on intervention as you can. We also need to make sure that what we record in our narrative or in our, maybe in this case it's going to be getting a hold of Child Protective Services or incident report for that we are factual, that we are objective. Just the facts. There's not a place for your opinion about why or what's going on. You got to look at just the facts. That's going to be what's going to give CPS or Adult Protective Services the tools that they need to help that individual out the most. Your opinion, it is not going to help. It's not going to make a difference in the long term. Sexual assault. When we deal with sexual assault, we have to recognize that there's a difference between sexual assault and rape. Sexual assault is unwanted oral, genital, or manual sex contact. Rape is where we're dealing with penetration. And by definition, this can be for both men and women. But we're talking about where we're dealing with some type of penetration to the body. Symptoms of sexual abuse, there's a multitude of them. And everyone's going to come and present differently who have suffered from sexual abuse. These can include things like nightmares, regressive behavior even, such as bedwetting, restlessness, truancy, withdrawal tendencies, hostility. They're more promiscuous, right? So they're more likely to want to have sex with others, especially in older children and teens. And then they may also have a phobia that's related to that specific offender, and we oftentimes will see that they turn to drugs and alcohol as a coping mechanism. When we think of these characteristics, it's more likely than the victimizers of an adult who have been physically or sexually abused than children. We know that that cycle will repeat itself. So if they've been victimized, right, they're more likely to be an abuser. We also know that those folks are typically alcohol and drug abusers. And in date rapes, in most cases, alleged assailants in such cases lives on a college campus. We have no idea effectively, and I can speak for all institutions of higher education. We are just now starting to get a hold of the amount of sexual assault that happens on campus. And that's not leaving out a community college through a university or anything in between. It does happen. It's just not reported. And that data is not collected always. And so there's a lot of work to renew that capability of the institutions. With date rape drugs, you're going to see the medication that they're using, a roofie or GHB, whatever you want to call it, is going to render that person unconscious or unresponsive, at least, unable to help themselves. It may weaken them to a point where they're unable to resist the attacker. And with some of these medications, we know that not only do they have a physical effect, making the person unable to resist, it also causes amnesia. And so it's more of a hypnotic property. It's like you would think of something like with Versed. Those components distort the victim's recall of what actually happened, on top of the fact that they may already be questioning if they should go to the authorities or not. Oftentimes leads to situations where we just get a lot of underreporting with date rape. Roofies is another one that we see here. Again, it's a benzodiazepine, just like you'd see with Versed or Valium. It's marketed in Mexico and South America. It is used for insomnia. It's 10 times more potent than Valium. So just give you an idea of how effective this is. That's a pretty significant drug. Takes place typically within about 20 minutes and lasts for up to 8 hours. Right? Now the other part behind this is the effects of roofies. Right? The effects of these is potentiated with alcohol, meaning it gets worse. Right? You see more compounded effects for longer periods of time, an earlier onset. All of that when it's mixed with alcohol, and primarily that's the way we see folks use it. So for this, what are the characteristics? Well, it's colorless, odorless, tasteless, can be dissolved into a drink without being detected, and alcohol makes it worse. So it's something that folks typically put into alcohol, and it's something that you can't see is there. That's why it's very important for ladies and guys, for that matter. Don't put your drinks down at an establishment without and leaving it unattended. Make sure you take it with you, right? Keep it with you at all point in times, or get a new one anytime that you depart from your drink. That's your safest bet, as you can think about it. The effects of it are going to be very similar to any other benzodiazepine. Central nervous system depressant. We're going to see amnesia, respiratory depression, and muscle relaxant. GHB is another example. We talk about this. Effects within 15 to 30 minutes, lasts up to 3 hours. Oftentimes you see this used by bodybuilders for amino acids. And then depressants with anesthetic type qualities. And then characteristics, it's liquid, it's odorless, and colorless. So it's another really good tool to incapacitate someone without them knowing, unfortunately. The effects of this, again, are going to be the same type of stuff that we typically would see. Relaxation, tranquility, sensually, and then a loss of inhibitions. There's a ton of street names for these. I'm not going to read through them, but you can see that there's a lot of them that you may see referred to or may not. Ketamine is another example. We've seen this. Ketamine, again, is a primary tool that we have now in our tool bag for anesthesia, or pain management, or disassociation. It also can be used for a date rape drug. Its hallucinogenic effects last anywhere between 45 to 90 minutes. And the characteristics is very potent. It's very potent. It's with very strong dissociative effects. Again, colorless, odorless liquid, but it will oftentimes have a white or off-white type powder to it. So we want to keep that in the back of your mind too, that we may see these as a white powder. Again, same common side effects you would typically see. There are some more significant ones with ketamine, hallucinations. Some of the big ones I'm thinking here are going to be respiratory depression, cardiac arrest, arrhythmia, seizures, and hypertension. MDMA, or ecstasy, is another one. It's one of the most commonly type of amphetamines used by teenagers and college students. Large dose equals the same effects of amphetamine, so things like doing meth, the same amount you would assume, large doses. Typically, you're going to see an onset within 20 to 60 minutes, lasts about 2 to 3 hours. 10% of the stimulated effects is based on the amphetamines, right? It's also a potent serotonin release. So you end up with all this serotonin, which makes you feel great. The problem is we can end up in a serotonin syndrome, and that's really dangerous. Temperature is the biggest thing that we see, because their temperature is going to rise. Oftentimes you see they're going to get hot, they're going to try to take their clothes off, they're going to be moving all over the place. Chills and sweating, things of that nature, those are very common. Psychological, we see mood alterations in sleep and anxiety. We see poor memory, poor impulse control. We also see the mixing with other medications. And the more you use it, the more they're going to build up a tolerance to it. Physical-wise, we can see everything from MIs to dysrhythmias to strokes, seizures, that serotonin syndrome we talked about, and then a lot of damage to those serotonin neurons. And we can see their temperature literally rise to as high as 109 degrees Fahrenheit. Talk about cooking your brain. So what are our responsibilities as EMS providers, as future paramedics? Well, we must provide a safe environment for an already traumatized patient. We need to make sure that we provide appropriate psychosocial care for the victim that's been part of an abuse or an assault. We also have to recognize that we have some legal considerations. We have a responsibility to report suspected cases to the appropriate law enforcement agencies. Specialized resources are going to include things like private and state or federal funding programs, the SANE program, which is a sexually assault nurse examiner's program. There's a multitude of those that are going to exist as part of those legal considerations to the responsibilities we have as healthcare providers. We know that as far as some of the legal considerations and the preservation of evidence, clothing should be only removed from a patient when necessary for assessment and treatment. Otherwise, we'll leave it on. It's not going to be a good deal to say, I need you to take your clothes off after getting sexually assaulted. We don't want to do that. We want to keep as much of the evidence in place as we can. We want to make sure that if they do decide to take their clothes off, or change their clothes, and they did that before we got there, that we take the clothes that they were assaulted in, we place them in a brown paper bag, one that will breathe and let moisture out so we don't destroy that DNA, so we can use that later for evidence. We also want to discourage any type of eating, drinking, urinating, defecating, douching, bathing, showering, smoking, anything, because we want to preserve that chain of evidence. And then remember, document, document, document. If you didn't document it, it didn't happen. And this is the biggest component that allows for you to be an advocate for your patient, is to be objective in your documentation and to be thorough. So in essence, we've talked about partner abuse, elder abuse, and child abuse, along with sexual abuse. Remember a couple key things. Abuse knows no boundaries. It can happen to anyone, for any reason, anywhere. It allows for us to be able to know what we need to look for, and then to keep a good, strong eye out, right? Keep a good set of full batteries in your BS-o-meter so you can determine if what your patients or what the scene is telling you lines up for the injuries that are consistent with abuse. Remember that taking the perspective of the victim oftentimes will allow for you to recognize what to do when you're unsure. Make the patient comfortable. Make the victim comfortable. And remember, keep it to just the facts. Be objective in how you see. Remember that you're not going to be able to fix this problem, but you can be supportive of it, and that you can be understanding and do everything you can to make the patient comfortable in these bad circumstances. And so with that, I'll see you on our next lesson.